Hello, my name is Dr. April Demito, and I am the Assistant Director of the FNP program here at Olivet Nazarene University. I have prepared a summary of the last 4 weeks of Nursing 671, and I hope that this may help you as you prepare for your upcoming final. I always start these presentations with the disclaimer that this is not meant to be your exclusive method to study for the upcoming exam. This is a summation of the information covered in the last 4 weeks, and it may be used as a guide to help you as you begin your studying for the upcoming final. So let's get started. Our first slide discusses Alzheimer's disease. And this condition is generally identified in the aging population. And however, there are some rare cases of early onset Alzheimer's. Most of the time, it is identified in seniors. Some of the steps leading up to the Alzheimer's diagnosis is performing a mini mental state examination on patients, and providers should have the skills in order to conduct one of these examinations on patients as they enter your practice. Now, if we have identified that Alzheimer's disease is what our patient is experiencing, one of the first line of treatments is cholinesterase inhibitors. It has been found to have some effect on prolonging the or delaying the onset. We've also identified that those who have Down syndrome are at an increased risk of developing Alzheimer's disease, so something to keep in mind. Now, dementia is an umbrella statement, so it covers many different terms. And it isn't Alzheimer's, but Alzheimer's does fit under the dementia umbrella. Vascular events, Lewy body, and frontotemporal also are underneath that dementia umbrella. It's anything associated with cognitive impairment. And with dementia, one of the first identified behavior patterns may be the patient's difficulty in finding words. So they may struggle to find a particular word for something. There are a lot of subtle signs that we see early on in these cases that we need to be aware of in practice. So we need to listen to our patients' families and any concerns that they may have. Myasthenia gravis, we typically will see this at a peak age in the 30s, and it is diagnosed with looking at the serum acetylcholine receptor antibody level. So that's how we diagnose myasthenia gravis. Now, seizures. There are different types of seizures, and you can see some, like an absent seizure. You may find the patient has a blank stare, all the way to grand mal seizures, where the patient will have uncontrollable jerky motions, but they can also have strange sensations and emotions, confusion, and aura, sudden falls. Now, there is a bit of a misnomer where seizures are concerned in driving. Now, that varies from state to state. So I actually, until I started researching for this presentation, thought that if you had to go a certain period of time seizure-free before you could drive, and that I didn't realize varied from state to state. So something, again, to keep in mind with your patients. Multiple sclerosis. And with multiple sclerosis, you can see that it is a demyelinization of the sheath that covers the nerve endings. And there is no real specific test to diagnose multiple sclerosis. There are different types of it as well. I had a patient recently who suffered, she's had multiple sclerosis since 1989, and she's on, immune modulators. And she walked with a cane, but otherwise she was managing her life quite well. And as I said before, some patients are on immunosuppressant drugs like fingolimod. Now, whenever you see a drug that ends in that olamide or olamide, not olamide, olamide, those are typically those DMARDs, and those are immunosuppressant drugs. Sometimes patients with multiple sclerosis will feel as though, and you can see here this numbness and tingling, it can feel like electric tingling in the extremities, and Depo-Medrol helps with those sensations. And there are, again, and we're looking at the different types of MS. One of the types is relapse remitting, so they go through periods where they may be asymptomatic, and then other periods where they need to walk with a cane or a walker or are even bedridden for a while. Great variations in this disease. Meningitis is an inflammation of the meninges, which is the covering of the brain, and it can present with headache, nuchal rigidity. They also may have a really high fever. Aseptic meningitis is the most common form of it, and it's a virus. So viruses are not treatable with antibiotics. Sometimes there is a case of bacterial meningitis, and this is very dangerous. Bacterial meningitis is often caused by strep pneumo, and that is can be deadly within 24 hours. So we need to treat quickly with cefotaximine. So we want a cephalosporin to treat bacterial meningitis, and we need to get it started quickly. That's why there's the new vaccine out, recommended for college-age children, called Bexsaro, and that is vaccine for meningitis group B, which is the bacterial meningitis that causes that, which can be deadly in 24 hours. All right, Guillain-Barré syndrome. This is a progressive weakness that occurs in individuals. It starts in the legs and moves up. And there's a lot of mystery around this illness. They don't really know what causes it. They do know that it can be preceded by respiratory illness, or it may be autoimmune. It can progress over hours to days. We do know that older women have a greater risk of developing these things. I had a friend whose mother experienced this, and she was hospitalized for quite some time before they identified what was going on with her. In fact, my friend, she was in a community hospital, and my friend was absolutely terrified because they just couldn't identify what was wrong with her, and so they transferred her up to Mayo Clinic, and within a few hours they had a definitive diagnosis, and she was undergoing treatment. Okay, Parkinson's disease. And this is a disease that occurs mainly in older people, but we have had some cases in the news, especially that have identified those younger patients, like Michael J. Fox. Freezing is the cardinal symptom that we see in patients with Parkinson's disease. And Parkinson's plus, they may have postural instability, so they are at a risk of frequent falls. We need to watch them closely and have them on fall precaution. Spinal cord injuries. Now, the deficit that occurs is greatly associated to the level of the injury. So you can see how this slide illustrates where the level of injury is and the absence of function. If you have a patient that has bowel involvement, they need to be on a bowel program, and that includes use of a rectal suppository and then digital stimulation. Often these patients will be regulated. So first thing in the morning, this is what will happen. They start their bowel program and do the rectal suppository, digital stimulation. They pass stool, and then that's the routine they do every morning. So different levels of injury allow for different involvement of the nerves. So different muscle groups may function. So look at the C6 injury here. If you have an injury at C6, they might be able to still use their shoulders. So if they can use their shoulders, they can transfer themselves from wheelchair to bed. And it gives, even though it's quite a C6 injury is a devastating illness or injury, it actually does give them a little bit more independence because they can still use their shoulders in some cases. Encephalitis. Encephalitis is, again, inflammation of the brain. So that's the difference between encephalitis and meningitis. Meningitis is an inflammation of the meninges. Encephalitis is an inflammation of the brain. It's most often viral in nature, and it can be transferred through mosquito bites. I know that for sure. And viral encephalitis presents itself with neuro deficits and headache. All right, now let's talk about depression and the different medications that patients will be placed on when they are suffering from depression. Now, mind you, this is just a very brief overview because this topic can be a course in itself, and it would be if you were becoming specialists in the field of mental health. But in depression medications, we see use of SSRIs often. And SSRIs and tricyclic antidepressants, they have similar effectiveness in depressed patients. We also want to consider that patients who are being treated may have a greater suicide risk because as they begin to have their mood lift a little bit, now they can actually think straight and a little straighter, and as their thinking becomes more clear, it actually may increase their risk of suicide until they get over that hump, and because they don't quite see the light at the end of the tunnel. One of the most helpful things about antidepressants is that they can greatly affect sleep disturbances. And with patients who are depressed, they often cannot go to sleep because they have racing thoughts. So it's almost as though their mind is on a loop and it never ends. Laying down to go to sleep actually just pushes that play button and that loop begins. Antidepressants can help stop that loop. And if the loop stops, then they're able to sleep better. Anorexia nervosa. This is a condition where patients don't eat. It's a distorted body image. These patients are best spoken to in a direct manner. So if you have a patient that you have built a rapport with, I wouldn't expect you to do this with a patient you've met the first time, or you could too. It depends on the relationship building that you do. If you have a patient that you suspect has anorexia, it's okay for you to say, I think that through the conversation that we've had, that you may have an eating disorder. You might not want to label them as anorexia, but it's okay to introduce that. Have you considered the thought that you may have an eating disorder? Patients who are anorexic run the risk of having having hypophosphatemia. So that's a common trait in anorexic patients. So those are things we need to look for in those patients. Now, bulimia is a little different. Bulimic patients go through this cycle of strict dieting, and then they stop and binge and purge, and then they feel shame, and then they go on the strict diet again. Now, there is actually a treatment, fluoxetine has been approved by the FDA to treat bulimia, and those who have low self-esteem across the board are at a greater risk of developing an eating disorder, whether it be anorexia or bulimia. That low self-esteem really puts them at a greater risk. Now, ADHD, and you can see here in this slide, I chose this slide because I like the way it illustrated the ADHD in the center and how you have these other conditions that influence ADHD. And patients who are on ADHD, they may be on drugs like methylphenidate or Vyvanse. Adderall is actually, that's what that is in generic form. All common medications. And for children who are on those medications, we need to watch their growth quickly, and also their growth and their weight. Post-traumatic stress disorder. This is not an uncommon occurrence. These are things we need to evaluate our patients for. There are certain diagnostic criteria that we see in patients who are diagnosed with PTSD. And this is common in people who are have been victims of violence, sexual assault, policemen, soldiers. Those who have experienced trauma in their life are at an increased risk. Bipolar disorder is a diagnosis that's not terribly uncommon, and you may consider initially with that a patient that is bipolar, they have these extreme highs and extreme lows, and that's true. But we have identified over the years that there are different levels of bipolar disorder. Now, for a patient to be diagnosed as a bipolar 1, mania must be present. So they must exhibit these characteristics that we see here on the manic side. Now, carbamazepine is often used as first-line treatment for bipolar disorder. It's a mood stabilizer, and it can help to even out those moods so there's less fluctuation and deviation, and they're more on a level playing field. Intimate partner violence. Now, there are many tools out there to identify whether or not your patient is a victim. One of the tools is called HITS or HITS, and this is a screening tool that stands for hurt, insult, threaten, and scream. And although it's not listed in this triad that I have here, it does have the characteristics in there of the patterns of behavior. The one thing we have found with those who are actually initiators of this violence are often victims, had been victims themselves at a younger age. Schizophrenia is another psychiatric condition. It is characterized by hallucinations and delusions. There are positive and negative symptoms associated with schizophrenia. Over the years, we have found that there are many treatments for schizophrenia, many drugs. Compliance to drug management is one of the biggest challenges in this population because the side effects are often untoward. It may make the side effects might cause them to gain weight. It might cause them to be tired. Um, we have also found that in this population that peer-delivered services have a much greater impact. So for this population, being in groups that are led by those who are also schizophrenic can be quite helpful. Hepatitis. All right, so what do we need to know about hepatitis? And there are different forms of hepatitis. And to be diagnosed with hepatitis, you must have anti-HAV IgM antibodies present. Some of the things to consider in teaching patients who have hepatitis is that their body fluids are infectious. So they should wear condoms if they're having sex. They need to be cautious if they are bleeding. Not have sex while on their period. Now, hepatitis A and B, they're not treatable. Now, we have found that there is treatment available for hepatitis C that can actually eradicate it. But A and B, unfortunately, is not, there is a vaccine for it, but there's not a cure for it. Cirrhosis of the liver. Now, this is cirrhosis of the liver, different levels of it, and it is a hardening or scarring of the liver. And as the liver becomes more scarred, it can function less. It can cause problems with clotting of the blood. So as we see that the liver becomes scarred more, patients may have bleeding issues. Also, where alcohol is concerned, women actually will develop cirrhosis more quickly than men, and they don't need to drink as much alcohol to get there. So another thing to consider in our population of patients. Pancreatitis. This is a incredibly painful condition. I had a friend who suffered from this. She had a couple bouts of it, and it was just, it was debilitating. She was in the hospital for weeks. It causes severe pain. You can't eat anything. Pancreatitis can be caused by a gallstone getting lodged in the bile duct. It won't allow for pancreatic enzymes to flow. Patients with pancreatitis need to be on a low-fat diet. And we may see that these patients have a bluish discoloration over the flanks, and that's called Grays-Turner sign. In order for a patient to be diagnosed with pancreatitis, we need to look at the Ranson's criteria. And I'm trying to think. I think that they need to have, I don't want to confuse you with that, but I think they have to have 2 of the Ranson criteria associated with that. End-stage renal disease. I just did a lecture yesterday about kidneys and how we have to really take good care of our kidneys. We have about 1 million nephrons in our kidneys when we're born, and that's it. We're not getting any more. So we need to take care of what we have, because once they're gone, they're gone. And patients who end up with end-stage renal disease most often is due to diabetes. So diabetic nephropathy is the most common cause of end-stage renal disease. These patients need to be put on a low-protein diet and have supplemental iron. So we need to keep our kidneys healthy. Now, this is a big word. Nephrolithiasis. All is a fancy word for a kidney stone. And you'll see an increase in kidney stones in the Caucasian population, and large doses of vitamin C actually increases the risk of kidney stones. Some other things that can cause an increase in kidney stones are patients who have elevated levels of uric acid in their blood. All of those things can increase the risk of kidney stones. Antibiotic resistance. We're seeing this more and more, unfortunately. This slide illustrates different ways that antibiotic resistance actually occurs. and it's often from emerging and then re-emerging infectious diseases. Also, the facts, what are other things that promote antibiotic resistance is the use of antibiotics in animal feed. So I only buy antibiotic-free, not produce, but meat products. Reforestation of farmland and counterfeit drug sales all contribute to antibiotic resistance. Ebola. I remember when this actually came to the United States a few years ago. I was working near the hospital at the time, and we were petrified because we would get lots of patients who would come to our clinic directly from the airport. And so we were really nervous about potential infected patients coming to our clinic. So they were prepared. We had the suits and the goggles and all of that stuff, but really avoid contact with any body fluid in a patient who has Ebola. And I tell my patients, worst case scenario, one of the things we were asking all the patients at that time, have you recently been out of the country? That was like every patient we asked that question to. The rest of our presentation is going to talk more about standards and practices affiliated with advanced practice nursing. And our first slide is the ANA Code of Ethics. Now, there are 9 provisions that make up the Code of Ethics, and they are comprised of a set of values and ethical principles to help guide clinical decisions. It also identifies conflict of interest and connects ethics and law. So, as a provider, we need to be aware of the Code of Ethics that we are committed to as we and this is for nurses. So as we take on the role, the code actually may change a little bit. So we may have more complex concepts that we deal with as a nurse practitioner than we did when we were nurses. And I put this one slide all together. Autonomy. Basically, this is respect for all persons and their self-determination. Beneficence, doing what's best for the patient. Non-malfeasance is first do no harm. And justice is treating everybody the same, providing access to care to everyone in our population, in the population. Now, insurance and malpractice. I have a whole presentation I do on malpractice because it's interesting. And I think that we can learn from others. But failure to diagnose correctly is actually the most common reason that people sue. And liability insurance is something that you'll need to consider when you're providers. Now, right now, Olivet is covering your malpractice insurance as a student. But when you're practicing, you'll need to consider that when you're working. Is the person you're going to be working for going to be paying for your malpractice insurance? Are you going to be in private practice? If you're going to have a private practice, then you'll need to cover yourself. What kind of insurance policy should I have? You need to consider things like a claims-made insurance. Claims-made insurance only covers situations when the incident occurred if the policy was in effect. So if I had something that occurred a year ago, and now I'm not using that malpractice insurance, so I have another malpractice carrier, that claims-made insurance policy isn't going to cover something that happened a year ago. So that puts me at risk. We also need to consider insurance and net income statements that demonstrate growth in assets. So lots of issues when we're in practice, especially private practice, and legal considerations. Now, I'm thinking of a case that I have in one of my other presentations, and the establishment of duty. So in order for you to be liable in a malpractice case, you must have established duty. Now let me tell you a short case. There was a nurse practitioner that saw a patient, and this was in a retail clinic setting. The patient received care and left the office setting and went to the pharmacy to get her prescription. While at the pharmacy, she passed out, and she was on the ground, and the store staff went and knocked on the door asking the nurse practitioner to come out and help. And she said to call the paramedics because she was afraid that she was going to put herself at risk for a malpractice case, or legal liability, I guess you'd say. So when I heard this case, I said, oh my gosh, that nurse practitioner put herself at great risk by not assisting that patient, and specifically because she had established duty to that patient. She had taken care of her in the office, she had made a diagnosis, she had prescribed a medication, so she had established duty. Now, if she were another nurse practitioner in the room next door that had never interacted with her, and someone came and knocked on the door and said, can you help this patient? There is no duty established, and she's under no legal liability to help that patient. Now, of course, now we've opened up a big ethical dilemma. Now, ethically, should she take care of that patient? So, see, there's so many things to think about when you are working as a nurse practitioner. Okay. Oh, another issue of high malpractice is lack of informed consent. And that's often in the outpatient area, doing things without getting getting formal consent and documenting it in your chart. And also, the big thing to remember is that happy patients don't sue. Okay, the LACE model. Now, LACE stands for Licensure, Accreditation, Certification, and Education, and it is the 4 pillars of regulation for all advanced practice nursing roles. And the Nurse Practice Act. The Nurse Practice Act establishes legal standards in each state, so it's different. And some nurse practitioners and nurses are governed by the State Board of Nursing. Some, like the state of Illinois, are governed by the professional regulation, the Department of Professional Regulation, but it varies from state to state. The Nurse Practice Act helps delineate boundaries of professional practice for APRNs. And there is something in the Nurse Practitioner or Nurse Practice Act which states statutory independent prescribing. And what that means is that nurse practitioners in all states are granted statutory independent prescribing authority. Reimbursement. Okay. Now, and billing and coding and CPT codes, so many things. I want you to really discuss these things with your preceptors so that you can have a good understanding of them. Research supports that nurse practitioner care actually costs a half of that of a physician. As all healthcare providers were challenged to reduce healthcare spending. And you may not realize this, but there was a period in time where insurance companies did not cover the care provided by nurse practitioners. And Oxford was actually the first insurance company to pay nurse practitioners for services. Now, there are so many different factors to consider where reimbursement is considered, and insurance reimbursement, like bundled payments and different audits that they do. You have to be able to substantiate what you're doing. So your documentation has to reflect your billing. So if you have a patient, now I don't know if you're at this level, but if you have a patient that comes in for a minor ailment and you're billing it as a 99214, which is it's up there, or 99215, you need to be able to justify billing that at that high rate. Otherwise, you run the risk during an audit to be fined for upcharging. So that means you're billing at a level that is too high, and you can get fined for that if it's unidentified. Healthcare reform. The focus of healthcare reform is to improve the outcomes, and it really is focused more on disease prevention. And I that's the one thing I think I've noticed in healthcare in my 30 some odd years in healthcare. I've seen that finally where they're looking at preventing the illness by early intervention. Now, most patients don't understand their healthcare benefits. So as providers, and they change all the time too. So I advise my patients, like for things like vaccinations, not all of them may be covered. Did you know that Medicare does not cover a tetanus shot unless there's been an injury? And if there is an injury and they need a tetanus shot, it will only pay for the TD. It will not pay for a Tdap. Now, these are all things that I've learned over the years working as a nurse practitioner. Medicare will not pay for the Shingrix vaccine, and it will only pay for one pneumonia vaccine. Well, there are two. So lots of things you need to consider as nurse practitioners. In fact, Medicare D, which covers prescription drugs, is relatively new. It really only came into effect in 2006. Before that, if patients did not have supplemental health insurance, they had to pay outright for all their medications. So gratefully Medicare D, and it's not great by any means, but it's better than it was, that's for sure. Well, that concludes our presentation, and I hope that you found this helpful, but again, I want to caution you, don't use this as your exclusive method for studying for your upcoming final exam. I hope you have a great night.